Good morning, everyone, and welcome to the first hearing session of the London Commission. If I could just give you a little bit of a background on the Commission itself. Most of us in this room have a great admiration to London being one of the greatest cities in the world, and this really, it's started by the Mayor's request to look at London's healthcare as it stands at the moment. Some of you may know I had the privilege of leading a piece of work in 2006, which was the London Framework for Action. And at the time, what was unique about that review, which was most ununique, over the last century, I think we've done a review of London's healthcare on a decade basis. So I think there were about 10 different reviews. I did look at the previous two. I remember the one before me was the Turnberg report, which was also a phenomenal piece of work. What was quite interesting from these different reviews, there was an incremental improvements in London healthcare, but there was never really that major disruptive improvement. And I think in many ways, the Mayor, Boris Johnson, is very keen to have a look at that again and see where we are within the landscape, which has substantially changed since 2006. We have 4 of the themes, and 4 of which are chaired by fairly distinguished people who work or associated with NHS London. The first theme is the discussion of today, which is how do we improve the quality and the integration of care in London. And this afternoon is the other theme, which is the health economy, research and education, which is the health and wealth agenda. So our aspirations is London dominates the world when it comes to its financial services. When it comes to the university sector and higher education, we have 3 of the best universities in the country. We compete globally when it comes to the biomedical research league. Why can't we have a healthcare system which is compatible with some of the excellence in other sectors in London? Today is the hearing sessions, and I'm delighted to have colleagues here who I'll introduce in a minute, who are being extremely generous with their time in helping the Commission. The call of evidence is part of, the hearing session is part of our overall approach to this, which is to seek opinion, call for evidence in relation to where we are in London, what is working, what is not working, how could we accelerate improvements in London's healthcare. And I'm very much looking forward to that, because although we're going to get a lot of written submissions, which we've extended till the 10th of February, I envisage this interactive session will be very, very rich in evidence, and it'll be a major contributor to the actual final report. So if I could go straight to the theme that we're discussing this morning. As I mentioned, 2007, we published the London Framework for Action, after which I did a runner, as you remember. I ended up being in office, and I remember that was a fairly sad day, leaving the troops behind, the people who did the significant amount of work. But I think they managed to do things even better without me, and a lot of things have worked. A lot of things that Londoners should be proud of, and some of these examples will come up today, like stroke care, some of the improvements we've seen in primary care, trauma centres. There are other things which haven't really worked as well, and the question is why. And hopefully today, from the different contributors over the last 5 or 6 years, and some of the political leaders, the clinical leaders, the managerial leadership over that time will contribute of what worked and what didn't work, and how we can drive these improvements in the future. And I think the landscape has also changed. As you know, the NHS structure has changed, although I really never had interest in structures, and I'm sure that will be touched on. But I think what I'd like to concentrate mostly is how could we work within the current structures, and certainly having the Mayor. And this is the first time I remember, and I've done a few of these reviews in my time, that we have a Mayor and local government really engaged in the change and driving the improvements in healthcare. And I believe that is very exciting. And obviously the London Assembly. Moving on into the other challenges, we are in a different world, the economy and the challenges we face economically and the impact of that. There are issues that remain challenging, mental health specifically, so we're going to spend a bit of time today to talk about mental health and where we are in London in relation to that. We know that the inflationary attendance of accident emergency department in London well outweighs the rest of the country. It did in 2007 and it remains so, and how we tackle that. And I know Andy, who's sitting on my right, has done some fantastic work in 24/7 working, and also the workforce challenges and how could we be a bit more flexible in workforce. Now, although this is theme A, which is mostly about quality, mostly about integration, I'm sure we're going to touch on the other themes if the opportunity arises or someone may wish to bring those up. So if I could move on to the panel. It's my great privilege to introduce the panel, and again, thank you for your time. I'm going to start with Councillor Teresa O'Neill from the London Borough of Bexley, who also sits on the Commission and also sits on the London Health Board, which is chaired by the Mayor, Boris Johnson. On my right is Dr. Andy Mitchell, who is the Regional Medical Director, London NHS, England, and also the chair of the group looking at today's theme. He's also involved in the London Senate. And Andy provides leadership to troops of clinicians who lead different pathways of care. And that's the unique thing doing this review in contrast to 2007, where there was essentially complete vacuum of clinical involvement and leadership at the time. And since then, things have moved on. And Andy, with his colleagues, have done an amazing job with the transformation of different clinical pathways. On my left is my boss in my real life, which is Dermot Kelleher, who's the Dean of the Faculty of Medicine. And he brings a wealth of experience from Ireland, where he recently joined us. Very fortunate Imperial to have him. Dermot is a clinician and also an academic, so he does both well, which is usually a challenge in that world. And we're very fortunate to get his experience and working in another city in previously Dublin being an interesting contribution to make. And finally, and more importantly, we have Mr. Nick Rainsford, a Member of Parliament in Greenwich and Woolwich, who has the wisdom and the memory of the Finance Commission, which was also another piece of work led by the Mayor, and also the political wisdom in helping me steering this. London always attracts a lot of political interest, and we're very grateful for your time. So, on that note, if I could then introduce our first person who's going to give evidence this morning, who I know is extremely busy, well known to all of us, Stephen Dorrell, the chair of the Health Select Committee. Stephen, you've seen it all. You've been around the block. I remember the first time I met you, which was, I think you were in office for 48 hours. You did a visit to St. Mary's. I was a very young person. I think you were younger too. You always had an absolute fascination about innovation, and you were very, very keen on that. We're absolutely privileged to have you. Thank you for your time. And I just thought we should give you a few minutes to say what you want to say, and then maybe we can get to some of my colleagues to seek some of your wisdom in where we're going. Thank you.
You're very kind, Chair, and thank you for the invitation to come and join you this morning. I was excited, actually, by the invitation to come this morning, because I do think that the initiative the Mayor's taken in setting up this commission to look at London's healthcare issues in the round is a huge opportunity. And I say that because not just in London, but all around the health service in the rest of the country as well, there are a series of problems that are illustrated in many ways in sharp relief in London. When I was thinking what I was going to say this morning, I started by writing on the top of the sheet that London offers the NHS in microcosm, and I thought that was an inappropriate word to apply to London. And so sharp relief is more accurate, I think. In London, there are world-class hospitals, hospitals with a global reputation, but they too often are overloaded by cases that shouldn't be there, and they are there because the community services that surround them aren't fit for purpose. And that is fundamentally my view of London healthcare, but also, as I say, it repeats itself all around the rest of the health service. It's worth, very often when we come together for these kind of discussions, we focus on structures. But what I wanted to do, having offered you that simple analysis at the beginning, is to look at the effect of that failure in terms of the lives of Londoners. It's worth reminding ourselves that despite over 60 years of the health service, which is supposed to be providing equitable access to healthcare, try and even out social distinctions, that within the City of Westminster, a single London borough, life expectancy at birth in different wards varies by 17 years. That's a startling statistic, in my view. And a second startling statistic, they're estimated now to be 80,000 dementia cases in London, of which 50% are undiagnosed. How can you treat a condition when you don't know which patients are suffering from it? TB rates in London, in some parts of London, some wards in London, are up to 6 times the national average and are the highest in Western Europe. Now, those are public health outcome measures, and I don't want to bore the Commission with lots of them, but there are several others that could be quoted that starkly illustrate the consequences of failure to deliver properly integrated services. Too much focus in the history of the health service, in my view, on the prestigious acute medicine, not enough on the services that surround those beacons of excellence. So that's where I want to go next. We all know that the majority of health and care should be delivered in the front line, in the community. One of the first points I want to make about this is to emphasise that community services are not the same thing as general practice. And I was looking at a presentation from NHS England, which I quote merely in order to illustrate how far we have to travel. This is a document that was circulated in London, headed London General Practice, a Call to Action. The first slide says 90% of patient contact with the NHS takes place in general practice. Simply untrue. The majority of patient contact with the health service takes place in community pharmacy. And if we don't understand that community services are a much broader concept than general practice, we haven't got to first base. So when I talk about community, one of my favourite questions, I think I'm right in saying I asked this question within a week of being appointed a health minister in 1990, now nearly a quarter of a century ago. Could somebody please explain to me the difference between primary health services and community health services? I've, in the intervening 24 years, learned that there is no difference. We're simply left with a set of institutional arrangements that were born of a political compromise between Nye Bevan and the BMA before the health service was set up. We have a series of silos that make it almost impossible for us to deliver the properly integrated, joined-up community services that is the only way, in my view, of delivering services that focus on the needs of individual people. We have pharmacy, we have social care, we have dentistry, we have opticians, we have general medical services, GPs. We have a group of people who are often excluded from this list who are the social housing providers, who are often genuinely on the front line. The housing manager is often the first person who sees an individual stumbling or falling or suffering from early onset of clinical conditions. So if we're to address the issue I started off with, which is world-class hospitals surrounded by community services that aren't fit for purpose, don't support people to lead normal lives as long as possible, as healthy lives as possible. If we're going to deliver that aspiration, we have, in my view, to look at the morass of different structures that seek to deliver joined-up services to an individual living in the community. How do we do that? I think we need commissioners in the health service. This is the challenge of being a commissioner in the health and care system, not just in the health service, actually, is to be much, much more open than the system has historically been to people with new ideas, whether they come from within the health service, within the social care world, within the third sector, or from the profit-making private sector. Simply declare ourselves open to people who have a new idea about how these challenges can be better met. Number of pointers there. We need to ensure that we're thinking through how digital technology can join up services and enable people to be more engaged in decisions about their own healthcare. Digital technology means that asking people to attend for a test is almost certainly, in many cases, not all, of course, but in many cases, is now less necessary, can be spaced out, and new technology allows people to be more engaged in those decisions themselves. It's an important theme for delivering better value services, better value in the sense of better use of money, but also better outcomes for patients, is to engage patients much more directly and to use technology not just to engage patients, but to join up the services that are delivered to them. So those are some themes that I hope we can explore this morning. Before I conclude, one question that's often left in the air when we talk about the opportunities for a different way of doing business in the community services is, what are the implications of that for the hospital service? It's often thought that taking resources out of the hospital service, quote unquote, that's an obstacle, and how do we secure extra resourcing, improved service delivery in the communities against the background of the institutional pressures facing the hospitals. And one of the thoughts I want to offer to you is that London is better placed than any other part of the NHS to find a way out of that box, because London brings together not just these community services that don't deliver, but some hospitals that have truly global reputations. And looking for opportunities for St Mary's, your hospital, or for St Thomas's, or for the London Hospital, or UCH, looking for encouraging those institutions to focus on what they're genuinely good at and where they can genuinely deliver value around the rest of this country and indeed beyond this country. That's a much better way of using those resources than it is turning them into very expensive primary care centres for which they're fundamentally inappropriate. So encouraging the hospitals to develop their own acute practice and at the same time developing better community health services in London. Those seem to me to be the two key themes as we think forward about how London healthcare delivery can be improved. Finally, the Mayor set up this commission. He's in a superb position to make the case for London as a global health centre, to make the case that London is open to new ideas about how to improve community-based services, and thirdly, and critically, to make the case that improved healthcare for London isn't something that's done to Londoners by institutions. It's done with Londoners, engaging them in decisions about their own healthcare through lifestyle, through diet, and through all the contributions individuals can make to healthcare. Healthcare isn't something, good health isn't enjoyed because you know a good doctor. It's enjoyed with the help of doctors and other clinicians, but it also engages individuals in their own lifestyle choices as well.
Thank you. Thank you for that. Thank you for those wonderful words of wisdom. I'm going to start with a couple of questions. But before that, you brought one very interesting point, which is how do you encourage people who have new ideas? These are clinicians, but I think you ended up by referencing even organizations. Historically, within the service that we've lived in, there's always someone giving you the permission to do that. And I just wanted your thoughts on that, because I agree, the biggest challenge is allowing people to come up with a new, not just a new idea, but a business model to allow that idea to thrive. Where do they go in this new landscape? And number one, and number two, what could we do in London to empower these people, whether they are clinicians, not necessarily clinicians, by the way, they could be managers, they could be people outside the health service. I read in a little analytical piece done in France recently that if they switch to digital technology, they will save 11 billion euros from outpatient visits out of their budget. So where do they get the permission from, and who's the person, which is the organization, where's the leadership from to make that happen?
Well, I think that's a very important question. Yeah. And if we were looking for a clear vision, route path that's going to take every part of London at the same rate through this set of challenges, then the prime responsibility, in my view, rests with the Commissioner. Because it's the Commissioner that provides access to public money. The whole point about commissioning, what used to be called purchasing, is that if you want to spend public money on the delivery of improved healthcare, there should be a burden of proof on you to demonstrate that you've looked at all the options available, and you're selecting from the options the best available. So it's a key part of it indeed is the core justification of the commissioning process, in my view. However, if we are going to wait for commissioners to find our way through all of these challenges, history suggests we're not going to make as quick progress as we need to. So that's the responsibility of commissioning. But whenever anybody comes to me and says, I've got a good idea about how care could be improved, your question, who do I sell this idea to? My answer is always, find a problem, solve it, and when you've solved it, seek forgiveness. Don't wait for permission.
Fair enough. Good point. Right. Councillor O'Neill.
Can I come in on the back of that? I think you're absolutely right, but when you consider commissioning, I'm about to have a meeting with my local CCG who are going to come in and be telling us how they haven't got enough money because the acutes rob all their money type of thing, and their bill has to be sorted first. So how do we get out of this conundrum that means that people start to work together so that the care is delivered at the right place and not necessarily by who has the first call on the money?
Well, the danger, if we start with the proposition that the acute sector's under pressure, therefore the acute sector has to get the first call of the money, is that you're always dealing with the urgent, not the important. And management in any walk of life is very often about creating space for yourself to deliver a longer-term solution. There was an interesting way of looking at A&E pressures, which is obviously one of the manifestations of this, that I was offered by an A&E consultant a few months ago. He said, of course there will be some people who have rightly to be at A&E, but accepting that, look at every single attendance in an A&E department and ask yourself, where did the system fail that led to this person attending A&E? Now, sometimes the system didn't fail and that individual needed to be there. But more often than not, either in the weeks or months or even in some cases years before that individual attended the A&E department, there was an opportunity for somebody to intervene to prevent that individual arriving at the A&E department, but actually, much more importantly, to allow that individual to enjoy a healthier life, to get more out of life. This isn't about saving money and relieving pressures in A&E departments. This is about enabling people to lead healthier, fuller lives.
Absolutely right.
Stephen, thank you for your thoughts, and I have to say I agree with everything you said. Thank you also for drawing to my attention one of the glaring errors in the document to which I'm a signatory, which is on the sort of where healthcare transactions take place, because you're quite right, most do take place in community pharmacy. But I think it raises the point of how we promote self-care, and that's a challenge in itself, because it's something of a paradigm shift from the way that people think about access to healthcare at the moment. And the challenge, I suppose, the question is, how do we go about achieving that change in mindset of the public?
It's why I concluded the remarks in the way that I did, that this, I think, is part of the role that public life politicians, from the mayor downwards in London, can play. I'm a huge supporter of the health service. But one of the traps of the principle that healthcare is free at the point of delivery provided by the state is that somehow there's a lazy habit of thought that that doesn't challenge, put it no stronger than that assumes that we can lead our lives, and when something goes wrong, there'll always be a doctor who'll put it right. Now, it's a very bad advice about how to lead your life. It's very bad medicine. And it's something that there is a requirement, it seems to me, to engage in a public dialogue about. I was thinking of who are the big public health institutions in London. Well, what about Chelsea Football Club and Arsenal Football Club? Engaging in community, when football clubs engage in encouraging young people to take part in sport, they're doing something young people enjoy, but they're also doing something to encourage healthy lifestyles and improve healthy outcomes. So political leadership that says your health is your responsibility, it's not something you can just turn up to the surgery or the pharmacy and get a fix. It's something where, in the awful jargon, you're a co-producer. I hate the phrase, but it's an important concept. That's an important part of the broader political message within which health and care should operate, in my view.
Thank you. You also reflected upon I suppose, the prestige of many London hospitals. The truth is, of course, they've developed around professional aspirations rather than necessarily what the public wants. And to a large extent, community services haven't developed in the same way. So there's a big disparity in spending currently between what we spend on acute services and in the community. We have to create greater collaboration, but also achieve that shift. Now, there are real challenges there, and I was wondering what your thoughts were about how we might promote that greater collaboration across the hospital community divide, because there is a divide that exists currently.
I think this is one of the areas where we need to follow up this concept, in my view, that of being open to new ideas. And one of the new ideas, not the only one, but one of the new ideas, I think in some parts of London we may wish to examine, is whether some of the prestige that attaches to these big acute hospitals couldn't be transferred into the community. Why, for example, in an area around St Thomas's Hospital, where there's a mixed experience of community services, why can't there be St Thomas's community services that have two effects? First of all, it would build public confidence about the quality of the community service being offered, potentially. And secondly, enable a more joined-up service between the community and acute sectors. If we look at how, the often quoted example, the Kaiser system in California, how that works, one of the things that's different between their system and ours is a much more joined-up service and common responsibility between the hospital and the community services. Now, I'm absolutely not advocating wholesale reorganisation of the structures, but we've set up a set of structures historically that make that extremely difficult. And I think that one of the things we should be, one of the options, and I stress one of the options we should be looking at, to try to improve the service, the quality of community health and care service. The St Thomas, use that example, St Thomas's community services will be no good if it's just medicine, because that's simply moving the barrier somewhere else. But if St Thomas's, to follow through that example, became interested, more interested, in the full integration of community-based services, that could be one way, and I keep stressing it, of improving the quality of the service that keeps people out of hospital. And again, I come back to the point, keeping people out of hospital, not because we don't want them in hospital, but because they don't want to be in hospital unless they absolutely have to be there.
If I can pursue that line again, we have, of course, in some parts of London tried very hard to achieve that shift from acute settings to community-provided services. But it does mean a reduction in the scope and scale of what some hospitals provide, which, of course, the public are very much against. And certainly in my role, I have the scars of places like South East London, where it's proved extremely difficult. Sometimes the barriers are actually political barriers as well. So I suppose my question is there a greater role that politicians might play in supporting clinicians who do recognise what the best value care pathways might be in achieving that change?
Yes, I do believe there's a role for politicians in that, because why do people react badly in a local community when the case is made for changes to the current model of acute hospital services? I think there are two basic reasons for that. The first is that the first time they hear about the need for change is when the local newspaper tells them something's going to close. Actually, in other words, the service is being changed without the need for change being established in the public mind. So focusing the discussion more on outcomes, on the need to deliver change services because today's services are no longer fit for purpose, that's a case which I don't think the clinical community can sign out of that responsibility, but I absolutely don't think the politicians can sign out of it either. Make the case for change, pose the question, and then offer the solution. That's part of the answer, part of the challenge, I think. The other thing to recognise is that when voters in any part of the country are asked to substitute their trust for a building and an institution, substitute for that trust in local community services, quite a lot of what we've been saying is that these services have historically not been fit for purpose. So they're not entirely wrong, are they, when they say that the service that they may have had in the past, substandard though it may have been in the hospital, is better than their recent experience of the community services. So we have to establish what the case for change, and we have to demonstrate seriousness of purpose about improving the community services. It's at the moment, people believe when there's a change to acute hospital services that it's because that we're short of money, we're going to cut it in the hospital, and they don't believe there will be the compensating improvement in the community services. So hence my point about looking for ways of improving public confidence in the community services, which is actually the way you'll deliver better care to them. But at the moment, they don't believe it. A, because they don't think there's a problem, and B, because their experience of those services historically has been too often poor.
Yeah, so thank you. So we need to make the case with more cogency, I think, don't we?
Beside that, if I just keep on this, beside the case for change, which we've managed to do reasonably successful in some parts of the country, I think there are good examples in London too. You make that, you also come up with obviously the solutions which are evidence-based, clinically led. But you also need to demonstrate to the public, to build the confidence that whatever is substituting that change needs to be up and running before that change has happened. And how could we work? And I think that based on the first question, you don't shut something before you actually show what is coming instead of it. How, with the current economic environment within London context, what ideas you can give us in relation to that? What assets do we have we can utilize to generate some capital to really demonstrate these changes? Because, you know, we had the good days. London Framework for Action was at the growth. Now we are static. Any thoughts on that in London specifically? Does London have unique assets that we can look at in this commission?
London has many unique assets. The challenge you pose, how do you demonstrate good services? London has a track record of having delivered improved services through some of these service changes. The most quoted example is clearly on stroke care, which is quoted, incidentally, not just in London around the rest of the health service, but internationally. It comes back to this point that London has the capacity to be a centre of excellence on a global scale. It already is in some of its acute services.
Yeah.
And making this, by being more open to flexible change,
Yeah.
I think London, there's an opportunity there for London. I think the best answer to your challenge, however, is to take a self-denying ordinance, to not imagine that among the six of us sat here, we're going to put our heads together, put a cold towel around our heads, and we're going to dream up a solution. But actually to throw open the challenge, and that's why I said to be much, much more open to other providers of care, whether elsewhere in the health service, out of different parts of London, coming across to offer care in other parts of London, and including the with-profit sector, because provided it delivers free access to care, if the outcome is better, that's what, surely in any other part of public expenditure, it would be regarded simply as bad practice not to test your commissioning decision against all the options available. We should apply that principle in healthcare.
Thank you. Thank you. Dermot.
Thank you. Some really very interesting and provocative points. And I guess if I come back to the old adage of what gets measured gets done, one of the big challenges, I think, is around the information technology area across London and across England in some senses, because the capacity to measure the outcomes of interventions at a community level in an integrated way are you know, they're quite difficult, aren't they?
Indeed.
And you've rightly mentioned I think some of the features of successful community intervention. One is you have to use community pharmacy. Secondly, you have to use allied health professionals. Thirdly, you've got to use IT. And fourthly, I think education plays a critical part. Education of patients and education of the health professionals who participate in the process to a different way of thinking and a different way of working. But I guess the real challenge is to actually get a means of measuring interventions and being sure that what we are doing in the best meaning way is effective. And I just wonder if I could get your thoughts on that.
Well, I agree with that. It is actually a challenge that, in the first instance, I would throw back to the clinical community, because for every clinician who tells me that it's in my specialty, it's difficult to measure outcomes in a properly neutral way, the same clinician will have a pretty good idea about which of his colleagues is competent and which ones are less competent. Now, it's recognising the strength of the first part of that argument, but trapping the second part of the same argument that I think is there's no perfect answer to your challenge, as you well know, but that's the best answer anyone can offer. The politicians are regularly challenged, rightly, to make the case for change. And I've said, I think that my peer group is too often defensive and doesn't step up to that plate. I think we should do that. But in providing a forum where the clinical community challenge each other about outcomes, the outcomes they deliver, That's the best answer. That's what true professionalism actually is about. It's one of the things I think the health system we've undervalued in recent years within the healthcare system is a proper understanding of what I mean by professionalism, which isn't, as Shaw famously described it, a conspiracy against the public interest. I think it's my favourite definition of what it means to be a professional is to suffer from divine discontent, never to be satisfied, always to believe there's a better way of doing something, and to trap that into a professional dialogue. It's one of the reasons why I'm a strong supporter of commissioning. If commissioning isn't just about looking at which provider can deliver the best value solution measured in money, it's also about providing a forum where the clinical community will challenge each other's practice in order to deliver better outcomes, better value outcomes, measured by the patient experience, what it delivers to the patient as well as what it costs to the taxpayer.
Yeah, I fully agree with you. I think it's quite appropriate to throw that challenge back on the clinical community, because it is the fundamental challenge that we face in terms of trying to construct a set of pathways that lead to better health across the community.
But if I may emphasise the point, it's where professionalism becomes hard-edged.
Yeah.
It's where saying, there's Jack Welch, when he was asked how he ran General Electric, one of the things he used to quote was that every year, every manager who reported to him had to deliver a list of the people who worked for him, with the 20% identified at the top who were going to be the leaders of the future, the 70% who were honest citizens who were going to be there in 12 months' time, and 10% who didn't contribute. And it was a sackable offence in Jack Welch's eyes for that 10% still to be on the payroll in 12 months' time. Now, I'm not suggesting that 10% is the right number in this context, but understanding how you enhance performance right across the range of service delivery, that seems to me to be something that the professions, it's a challenge where the professions still have some way to go.
Can I just take up one further point, and that is about the implementation of public health measures, and they all depend to some extent on a level of compliance, and that's compliance by the professionals and also compliance by the patients. That involves education, it involves communication, and it involves the capacity to reach out into those individuals who have a 17-year less life expectancy in the community, which is challenging. So traditionally, that's typically, or it's often placed as an either-or with regard to acute services, particularly in budgetary terms. But in some senses, to actually reach out to those individuals who have got the lowest life expectancy, who've got the biggest social deprivation, not the ones who are going to be digitally active. That's an expensive process, and I wonder if you could articulate how you see we should manage the investment that's necessary to get that social population moving in a way that's not either or with regard to the acute services. I think ultimately it will be, but in the immediate term it needs a different type of action.
Well, it also, it's partly, isn't it, it's about breaking down the divorce between the acute and the community services. It's why, for example, when there are GPs in A&E departments, and it doesn't have to be GPs, incidentally, to go back to an earlier theme, other professional intervention in an A&E department, where some of the people who attend, as we know, not just in London, inner city A&E departments, it's almost a kind. It's a form of social engagement, and offering a different form of social engagement would enhance the value of that individual's life. So it is about going back actually to a point I made earlier. Of the people who attend A&E departments, ask ourselves why they were there, why they're there, and what earlier opportunity existed to improve the quality of that individual's life and thereby prevent them needing to come to A&E department.
Thank you.
Can I ask you about the issue of proximity? There's a paradox here. I mean, the public perception, not just the health service, but many other services, take the fire service as an example, is having a facility, fire station, hospital, very close to where you live is seen to be a good thing, and there's resistance to closing it when that's proposed. But actually the evidence of stroke and trauma and elsewhere is that if you can have a small number of highly specialist centres and get people there, even if it means the ambulance going past an A&E on the way, that probably will deliver a better outcome. So how do we overcome the proximity principle, number one, and the public view that proximity is important? And equally, and this is the second part of the question, how do we make sure that community services, which are truly in proximity, get the benefit of the public's preference for services being in close proximity to them? We haven't really succeeded in that.
No, we haven't. Partly because your profession and mine too often says you need to, it's an easy way to curry favour to not to challenge what seems to be common sense. And actually, the way you challenge quotes common sense is by demonstrating the evidence. Now, we all know you'll never win. You shouldn't set out in a public argument with the objective of winning it unanimously. But unless you engage in the argument is never made. And so I think the challenge to the politicians with clinical support, because actually this is about better clinical services as well, neither of us can sign out of this, is to make the case based on the evidence. If we've got A&E departments that deliver poor outcomes, if we've got stroke services elsewhere in the country that don't deliver outcomes that match what's available in London, if we've got outcomes that with wide variations in different parts of London, and we know we have, then demonstrate to the local population in the areas where the outcomes are poor that there's a problem. It's back to this point that so much of politics is about defining the problem. If you define a problem, then people are interested in the solution. If they don't think there's a problem, they're not really convinced that when you offer them a solution, you're not offering them something that is motivated by some other motivation.
Thank you. Thank you very much for that very rich discussion and your ideas. And I just wonder if I could ask you one last favour, is throughout the period of the Commission, if we can intermittently come and seek your further thoughts privately, and if there are any other thoughts that you wish to send to us, will be much appreciated. So thank you again for your time. Thank you.
Thanks for having me.
Thank you.
Thank you.